Thank you for that very kind introduction, and thank you, Dr. Keller, as well for inviting me. So I'm going to try to go through this very important topic. I hope that some of you at least attended the opioid reduction session yesterday, which will have gone into this topic more in depth. I have no disclosures. We've all seen the headlines of the toll of the opioid epidemic, the death and the destruction, the addiction, and it's cycling through families from neonates having to go through withdrawal every 25 minutes in the United States from opioids. We know the epidemic by the numbers published by the CDC. Over 10 million people misused prescription opioids in just the past year. And it's getting worse. When we look at our states, the United States, we see that there are a number of states who have a high level of drug overdose deaths. This is from data from 2019. And if you look further down, more granular data in terms of counties, the national rate of opioid prescriptions is 43 scripts per 100 people. That would mean that all of us really in the room should be on scripts. And some of the counties are 9 times higher than this. This is an astounding problem. And why is that important to me? Because I work in the city of Baltimore, which is both a vibrant, exciting city, a big foodie town, but also a troubled one. And I imagine there are cities like that all over our country. What is our role as surgeons? We know that there's been a systemic problem here in the United States, at least, that fueled this problem of opioids. From an American ideal of us living without pain and mandates from our government to ask about pain, and has your pain been evaluated on all these survey questions that our patients get? And us and our other healthcare providers trying to address this problem. But it's led to this, where there's 142 million opioid prescriptions that were made in 2020. Even among patients who have undergone overdose, 91% of those patients then receive subsequently an opioid prescription. That is astounding data to me. There is also, you would think that patients who have just minor surgery, who've never been on opioids, they are also at increased risk for opioid misuse after this. And the majority of the patients, though, fail to use their entire prescription. We need to really look at dosing guidelines from the University of Michigan, Tellum's institution, as well as Dartmouth, to see, are we prescribing the right amounts? Because 90% of our patients fail to dispose of these pills properly, which means we are also getting these medications and chemicals in our systems when we drink the water. There's a higher incidence of adolescents of prolonged use after procedures when they're getting opioids if their family members are chronic users. So it's important for us to look at this. How have we done? There's been an increased awareness, but there's a static level of opioid use over this 10-year study. Even as the increased use of acetaminophen and gabapentinoids have increased, NSAID use is stable, and so is opioid use. You can see in the black line here on this graph. And the pandemic has made this worse. From 2019 to 2020, there's upwards of 30% increase in opioid use, and this amounts to 23,000 deaths in 2020. I won't go into this in much detail. Dr. Kripada gave a very nice presentation about this, but we know as surgeons, we address nociceptive somatic and visceral pain, as well as neuropathic pain. If you're a GI surgeon, we deal with that type of pain a lot, or if you're a hernia surgeon, we're dealing with these chronic pain patients. So how can we address this? Well, it can't start with our anesthesia colleagues, because there is an option for opioid-free general anesthesia. In this systematic review and meta-analysis, which included 26 randomized controlled trials, opioid-free, that's hard to say, anesthesia significantly reduced adverse postoperative events. This was primarily decreased nausea and vomiting, but it also decreased postoperative opioid need and consumption. And meanwhile, there wasn't a significant increase in postoperative pain or the length of stay in the recovery room. The most used regimen is dexamethasone infusion. I'm sorry, it's late on a Friday. This shows the loading dose. This is usually followed by propofol and then a muscle relaxant. We can, though, not just our anesthesia colleagues, but we can also be part of the solution by performing anesthetic blocks. Though we won't necessarily get paid for this, there are some colleagues that potentially can get facility charges, or if you have a colleague do the tap block for you, you might also get paid. But the important thing is that our patients can benefit from this, regardless of payment. Local anesthetics block the sodium channels of these nerve endings, and so it blocks the transmission of these nociceptive pain signals. It also inhibits a local inflammatory response. So we can do blocks in various areas, transversus abdominis plane block, which I'll share with you. The rectus abdominis block, we use this if we put ports, for instance, along the rectus, or we're doing a retrorectus hernia repair. This can be important space to really block. And you can also do a transversalis fascia block. You might have seen in some of the hernia sessions how this plane can be used quite frequently, so it's important to do that. And I'm going to highlight as well the quadratus lumborum block, which you might not be familiar with. This comes from our OpiVoid site. I'm proud at Sages that we had this opioid task force, and we now have a trademark OpiVoid site, so check this out. The TAP block has been shown in multiple studies to show benefit across multiple different procedures. It decreases pain, it decreases opioid use, and time to ambulation. You can do this by ultrasound guided, but a lot of us perform laparoscopic or robotic abdominal surgery, and you can see the transversus muscle from the inside, and that's typically how I do it. Does it matter when you do it? Before anesthesia induction in the preoperative area or after induction? It really doesn't. But if you wait until after the surgery is completed, you might see in those first 4 hours higher pain scores among your patients, as well as a higher need for additional medications like ketorolac. However, the TAP technique is not standard, and the surgery, when this is studied, has not been standardized either, but it does seem to make a difference. This is from my partner, Dr. Coker, and shows one technique of doing the TAP. This is using an aspiration needle, a very quick technique to use. It delivers the bupivacaine in short order. And you can see that the horizontal lines of the transversus in this. I actually just go in externally with a 22 gauge needle and deliver that as well. But you want to see that nice bulge of the transversus muscle. The quadratus lumborum block, I think, can be very helpful. It's not something really that we probably do as surgeons, but our anesthesia colleagues can do, but I'll show you a slide where this might differ. So the quadratus lumborum muscle, you might not remember from your first year anatomy class, but it lies adjacent to the psoas muscle and abuts the diaphragm. And if you do an anterior block, it can attain a more superior blocking level above that because a local anesthetic diffuses up into the thorax via the arcuate ligament pathways into that thoracic paravertebral space up to T6 and can block those spinal nerve roots. There are some disadvantages. It can take a while for that effect, but if you do this early, then you can have that lasting effect. And it does require a large volume or dose of that anesthetic. There's a nice study that illustrated this and the access using ultrasound. You can see the diaphragm here. Let's see here. And the quadratus lumborum, and in the red is where that anesthetic is gonna, or this is the red of the muscle. And here's the needle coming immediately in this triangular space is where you're aiming for. You can see how the local anesthetic has filled that space. But if you're doing retroperitoneal surgery or a median arcuate ligament release, you're here. And you can inject a needle. This is shown here laparoscopically and by a urologist who's doing a nephrectomy, perhaps a retroperitoneal adrenalectomy as well. You might access to this space as well. How can we otherwise avoid it? Well, we can by using multimodal analgesia. NSAIDs I won't talk about much. We're all familiar with this and its actions. There have been trials that show that it doesn't, if you substitute some of the opioids with NSAIDs, it doesn't really harm the pain control, but it can reduce the nausea or vomiting. There can be some side effects. Of course, we have to be careful in folks who have decreased renal function and who are at risk for bleeding. Acetaminophen can be given orally, rectally, or intravenous. Stephen Cohn did a study that showed mixed results for intravenous use in a review because it is higher cost, but it does reduce nausea, vomiting, and patients who have bariatric surgery, for instance, esophagectomy, where taking oral medication may be challenging. It can reduce pain compared to placebo and the additive in terms of the opioid pain reduction. Is it possible to give no opiates at all? It is possible. This is a study that was very interesting that looked at acute care surgery. So patients who came in with acute appendicitis, acute gallbladder symptoms, whether that was cholecystitis or symptomatic gallstones, and almost 88% were satisfied or neutral with their pain control at discharge, and at 2 weeks rated a very high quality of life. Now maybe that was because they came in with pain, we removed the disease structure, and they felt better, but it does show promise that we can go through surgery without opioids at all. Gabapentinoids have gotten a lot of press, and we saw on that initial slide that its use has been increasing over the last decade. This can, attacks the calcium channels, decreases the calcium, calcitonin gene-related peptide glutamate. Pregabalin has a better bioavailability, but for both of these medications, the dose should be lowered or even avoided in patients with renal failure. We have to use caution as well in our physiologically older patients because there are side effects of dizziness, which might increase the fall risk. Some patients will have nausea, and certainly we have to be careful about increased somnolence. Over-sedation is a risk, especially when it's coupled with opioids. There's potential for further respiratory depression, which we have to have caution about. And in some patients, their creatinine clearance might go down a little bit depending on what's going on in the postoperative state, and so you have to adjust the dosage accordingly. What about antidepressants? Tricyclics can be adjunctive, especially for cancer-related pain and patients with depression. Patients who come in with chronic pain, for instance, you're trying to get them off of opioids even in their postoperative state. This can be used as adjunctive therapy. It may also be helpful as neuromodulator therapy in functional GI pain, but we have to be careful in older patients who are at risk for orthostatic hypotension and side effects of delirium. SSRIs are not well studied. Lidocaine is an important adjunctive, and so I just want to share this with you because perioperative lidocaine infusion has been shown to increase the pain scores after abdominal surgery, decrease opioid consumption, and it also reduces recovery time after ambulatory surgery. You can also use lidoderm patches, topical lidocaine. There's minimum absorption from that, but you still have to be careful on patients at risk for heart arrhythmia. Ketamine, I have to hurry up because I'm running out of time. Ketamine is a short-acting anesthetic. It's a dissociative hypnotic. This is a common dosing that's used, and this is can be very helpful, especially patients who come in who need surgery, whether acute or elective, but who have chronic pain. And so you can give a bolus and then an infusion. We can use lidocaine as well as ketamine drips on the regular floor at our hospital, and so hopefully you can do that at yours as well. This can reduce postoperative pain medicine consumption and the pain intensity. It probably mildly also reduces nausea or vomiting, but you have to be careful as you are tapering off the dose because some patients will end up with an emergence delirium, which is a high dissatisfier. Okay, thank you. Because we're in Colorado, I had to add this slide in on cannabinoids. So cannabinoids, it has been shown in animal studies to be helpful, but we don't really know in humans. The results are inconclusive. Its most promising use is among cancer patients. It may be helpful in patients who are really trying to stimulate appetite as well. But there's few studies looking at this for acute surgical pain. However, there is some data showing in states that have legalized marijuana that the opioid dependence might be less. It's still to be determined. BMI is up. So what about some alternative therapy? Not something that we often think about as surgeons, but we can think about mindfulness. Cognitive behavioral therapy I use for patients with chronic pain, to try to reset that mindset about this and how you can adapt to pain that you might feel. Diaphragmatic breathing, pet therapy. Some hospitals do allow pets in, and that's my dog. Okay, I wanted to share with you our website very quickly. This has lots of information. It can tell you links to your state drug monitoring programs, some tips on pain management, more information on these infusions that I highlighted, as well as patient education tools. Again, setting expectations and educating about opioids. What can you do? Own the problem, make yourself and your team part of the solution. So learn your state laws, follow the guidelines for dosing, learn how to do blocks. Partnership, collaborate with your anesthesia colleagues and your team. Inquiry, talk with your patients, find out about their personal and family history and set expectations. It's not zero pain. They are gonna have some discomfort after surgery. Video education, you can go to our website and look at that, share your knowledge. Opioid perioperative reduction, of course, and ARS protocols. Look at inequity as well in your community. What's going to just derail their recovery, and how can you get through that? Maybe it's depression. And then discharge planning and education. So thank you so much for the time. I'm sorry that I went over.
Thank you so much.